Hello and welcome to Motivational Midwife. Today we're going to look at postpartum hemorrhage. So looking at postpartum hemorrhage, what is postpartum hemorrhage? Well, the RCOG define it as bleeding from their genital tract following the birth of a baby that exceeds 500 mils from a vaginal birth or a litre from a caesarean section. But the key point in this definition is any amount that compromises the well-being of that mother. And how are you going to recognise this? So sometimes it's very obvious. In fact, a lot of the time it's very obvious that you've got bleeding that is more than usual. But sometimes there can be very subtle signs. If you have something like a hematoma developing internally or bleeding into the broad ligament following a caesarean section, you may not be quite so sure what's going on, and your only key symptom would be that the woman's condition is deteriorating. So she may become pale, she may be restless, her level of consciousness may be affected, and there may be an atonic uterus. And as her body is trying to compensate for that loss of circulating volume, you will start to get your signs and symptoms of hypovolemic shock. So the increased rest rate and pulse rate as the catecholamines are released, and eventually you will get your drop in blood pressure. So primary postpartum hemorrhages are those that occur within 24 hours of birth, and we're usually quite good at recognising those that happen at birth. What we are less good at is really cumulatively totting up the blood loss for those women who have a blood loss maybe of 300 or 400 mils at birth, and then in the few hours following birth they keep having a little bit of a gush and then it stops, and then a little bit of a gush and then it stops. And really we should be thinking about adding that on to their post-birth blood loss, because very quickly they can tip into that 500 mil plus blood loss. Secondary PPHs, you don't see very many in maternity because the women tend to be out of our remit for a lot of these. They are most commonly because of retained products or infection. And how often does it happen? Well, it's very difficult to find some really current figures on just exactly what the incidence of PPH is. So I would suggest that you look at the figures within your own working area, your own trusts, to get a good feel for what this problem is in your working area. But the RCOG suggests that about 6% of births are affected by primary postpartum hemorrhage, and that secondary is sort of 1 to 3%, but it could well be very much underestimated, as it may not be deemed as a secondary PPH. The 2018 MBRRACE report gives a mortality rate of 0.78 per 100,000. So it is potentially, if we don't manage it well, a fatal issue. So we're looking at our T's. A lot of you will be aware of the 4 T's of postpartum hemorrhage, and we just add the 5th one on as theatre, because obviously if we can't correct it, that's exactly where we're going to end up, is in theatre. So the most common one for us as midwives is tone. 70% of postpartum hemorrhages are due to tone and an atonic uterus. Hotly followed by trauma at 20%. So this would be your cervical, vaginal and perineal tears. And not forgetting caesarean section as well, because that is a trauma issue. Tissue, so your retained products, ragged membranes, can cause postpartum hemorrhage, as it affects the uterus's ability to actually contract. And then less than 1% are actually due to clotting issues, due to those thrombin issues. And hopefully you would know about those before you were looking after somebody in labour. So thinking about risk factors, and this list is not exhaustive, but if you have had a PPH before, you have a 3 times increased risk of having another one. So it's very important antenatally that we speak to women who have had a previous postpartum hemorrhage, and also find out why they had that hemorrhage. If it was to do with trauma, then actually they may not be as at risk of having a PPH the second time. But obviously, if it was an atonic uterus, that does increase their risk. So you need to be having that discussion with them and giving them all the information that they can make an informed choice about having or not having prophylactic drugs and IV access, rather than just presenting it to them as a fait accompli when they actually come in labour. Retained placentas, obviously, if there is anything in the uterus that is going to affect its ability to contract down, and caesarean section, as we've said, can have an increased blood loss anyway, because you are cutting through all the tissues and blood vessels. Raised blood pressure, PET, could lead to clotting issues. Our long labours and augmentation and inductions, if the uterus has been working very hard for a long time and we've had to then augment it, there is always the risk that it will struggle to contract post-delivery. Anything that's in the uterus or any issues with the uterus, things like fibroids, can affect its ability to contract. And if we've got large placental sites, such in the case of multiple births or macrosomic babies, then again, that can affect the uterus's ability to contract down. And also you've got a larger site that the bleeding can be coming from. Anemia in itself, it doesn't increase the risk of them having a postpartum hemorrhage, but what it does do is lower the threshold for the woman's ability to actually cope with blood loss. So this is why we really encourage women to have a good hemoglobin before they go into labour. Infection can affect the clotting, and instrumentals, obviously with most instrumentals, particularly forceps, less so with kiwi deliveries, often come with having an episiotomy, and doctors' episiotomies are often much larger than midwives' episiotomies, so the potential for excess blood loss from that trauma is greater. Be very wary of anyone who's had an antepartum hemorrhage, as they are more likely to have a postpartum hemorrhage, as it can affect the ability for the uterus to contract down. Our grand multips, their uteruses have worked very hard, so again it can be a tonal issue. And general anaesthetics affect the uterus's ability to contract as well. It can relax the uterus. So if you're looking after somebody who has had a general anaesthetic postnatally, just have that in the back of your mind. So how are we going to manage that? Well, our midwives' competencies and our code of conduct, state that we can certainly start emergency care, but we do need to refer appropriately. Okay, providing you've been trained to do that emergency care, and you will have done during your training. So the first thing we need to do, though, because we cannot manage this emergency on our own, is call for help. So if you're in a hospital situation, you pull your emergency buzzer. If you're in a home situation, you need to dial 999 and get a blue light paramedic ambulance. You'll want other midwives in the room, and you'll want your senior midwife in the room to help you coordinate the care. You'll need people to support the partner and look after the baby. And in terms of delegation, because it is, as you're a midwife, you are accountable for who you delegate jobs to. So you need to make sure that those people that you ask to do things actually have the skills to do what you're asking them to do. So midwives, SHO, they can put the facial oxygen on. And remember, if you have watched the session on shock, if we take a nice top to toe approach, we'll put our facial oxygen on at 10 to 15 litres to help support that respiratory function and cardiac function. We'll need to allocate someone to undertake those observations, which may be 3 to 5 minutely, maybe 15 minutely, depending on her condition. And you'll want a temperature, pulse, respiration. You'll want the blood pressure, which initially you're, because women compensate very well, you're expecting to stay relatively stable. The temperature, you're not expecting very much of a drop, but if they're losing a third of their circulating volume, you really should be taking that temperature every 15 minutes as well. Pulse and respirate, you're expecting to increase as the body is trying to compensate for that loss of circulating volume. And your capillary refill, which should be less than 2 to 3 seconds, it may well take longer because there is less circulating volume. Your oxygen saturations, you want them to be above 95%, and certainly having that facial oxygen on should help you achieve that. Her level of consciousness, her CAVPU, needs to be assessed. And I say, once she's lost a litre, you should be doing that temperature every 15 minutes. We need to get someone to get 2 wide bore cannulas in, so these are your big grey ones, and get some bloods out. So full blood count, group and save, cross-matching 4 units, all the maximum that your trust will allow you to cross-match. LFTs, U&Es and clottings will give you a baseline. We've got some bloods out, so we need to put some fluids in, and we can have a litre of crystalloid up straight away. You can put that up straight away, but remember, any of these things, it's your responsibility to make sure that the doctors have prescribed everything that's gone up after the emergency is settled. So a maximum of 2 litres of crystalloid, colloid a maximum of 1.5 litres, so a maximum of 3.5 clear litres of clear fluids before we really do need to be thinking about blood. We've got fluids going in. We need to watch what's coming out quite carefully, and also we know that tissue hyperperfusion is going to affect the kidneys fairly quickly, so we need to monitor that urine output very closely. So catheterizing, and also for postpartum hemorrhage, catheterizing and emptying the bladder will help the uterus contract down as well. So catheter in, hourly bag, and we're looking at 0.5 ml per kilo per hour from a urine output point of view. Key is to assign someone to scribe for you, and certainly some of the MBRRACE reports, and well, many of the MBRRACE reports do highlight that this is something that needs to be done in emergency situations, is someone needs to be allocated to scribe what's going on. So the who's in the room, what they're doing, when it's happening, any drugs that are given, any manoeuvres that are done, anything at all. And then you as the midwife will transcribe that documentation into your notes and add some rationale to it as well. And then those documents will be kept for 25 years. So your registrar and your consultants, they are the decision makers, co-decision makers with the anaesthetists. And if you're getting up to a sort of 1,500 mils, if you haven't called your consultant, you really need them to be on their way, because they will take a helicopter view of what's going on in the room and help make decisions. By about 1,500 mils, in most trusts, you should be activating, if your trust has one, your massive obstetric hemorrhage protocols. Anaesthetists and ODPs, they are the experts in airway management and really do need to be involved, and particularly if we are heading for theatre. And haematology also need to be involved because obviously if you're activating hemorrhage protocols, you may or may not be aware, but generally in most blood banks, and if you activate a massive obstetric hemorrhage protocol, all other work stops in the lab until they have sorted that out. So you do need to remember to stand them down once your emergency is settled. So let's think about treating the cause. So we've generally got our top to toe management done. So what's causing this? Okay, so we've said 70% are due to tone. So as a midwife, the first thing we're going to do is rub up a contraction, and this will expel clots and help the uterus contract. So you're wanting to put your hand on the fundus of the uterus, really firm pressure, and rub that contraction up. If the bladder has not been emptied, you haven't got your catheter in, get a catheter in, and that will also help. So the drug regimes that we're looking at here are from the RCOG guideline, but they may vary slightly in your individual trusts. So do look at your own trust's guideline for the management of PPH, but most will follow this regime in some way, shape or form. So active management, they will have already had 10 units of syntocinon. Therefore, you can give 5 international units of syntocinon IV, and you don't necessarily need to have a cannula in to do this. If you think about how you take blood, you're essentially reversing that process to put the drug in. So don't delay. You as students can't do IV drugs, but the midwife can. There are 500 micrograms of ergometrin, which can be given IV or IM. Personally, I prefer to give it IM. Be mindful if they've already had symptometrin as their third stage drug, because that also has ergometrin in. And we can only give 2 doses within 24 hours as midwives. Then you'll want somebody to be getting a syntocinon infusion ready. So 40 international units of syntocinon in 500 mils of normal saline, or some trusts have it in 36 mils. But what you're actually aiming for is to administer 10 international units for each hour for 4 hours. Early bimanual compression is actually a really good way of managing postpartum hemorrhage, particularly if you're out in the community. And this would be that you'd have one hand on the fundus and the other hand as a fist is in through the vagina, and you are compressing the uterus between your fist and your top hand that's on the fundus. And it actually can help minimize the blood loss until you get some of those drugs in. Carboprost is 250 micrograms and must only be given IM. Do not ever give this IV, as you will kill the patient. And it can be given every 15 minutes for a maximum of 8 doses. However, I would say if you're up to carboprost, you really need to be thinking about going to theatre. You don't want to be sitting in a room waiting 15 minutes to give another dose, because that's essentially 2 hours worth. And if she's bleeding heavily, you don't want to be in your delivery room. You really want to be in theatre seeing what's going on. And carboprost is on the midwives exemption, so it is a drug that we can give that first dose of anyway. Misoprostol, now this will vary in trusts. Some trusts give 800 micrograms, some 1,000, and it's given PR. It's not a very nice drug, and it does have some horrible side effects, such as diarrhea and abdominal discomfort. Carboprost should be contraindicated in people with asthma, and misoprostol with anyone with cardiac problems. A lot of trusts now give tranexamic acid. They give 1 gram IV, particularly if the bleeding is thought to be a trauma-related issue. And also if it's a clotting factor, then factor 7 can sometimes be given. So if we're thinking it's a trauma issue, check for tears, and really you need to be putting her in lithotomy, have a good light so you can see well. Check the vaginal wall, make sure you can visualize the cervix to see if there's an issue there, not just the perineum, and obviously suturing it promptly. And you may find as a midwife that certainly if I've got one that's bleeding a lot, I may well ask my doctor to do it, because they are stitching much more frequently than I am, so they can probably do it a lot quicker than I can. If we're thinking that there's a tissue problem, make sure that we have delegated someone to check that the placenta and membranes are complete. And the least likely cause, thrombin, if you're looking at the blood, it will be viscous, it won't be clotting. So have a look at what bleeding, that if there's blood on the floor, is it still runny or is it clotting? If we end up going to theatre, there are a number of things that can happen in theatre. The uterus can be packed. They can use a Bakary balloon, which looks a little bit like a catheter and the little balloon on a catheter that we normally blow up to keep in the bladder, it's a similar thing. It blows up once it's in the uterus and it applies pressure to the uterine wall. A B-Lynch suture is one that will essentially loop over the uterus and pull tight. So again, it applies pressure. You don't see very often a uterine artery ligation anymore. So really that would be tying off the uterine arteries. We don't see it very more, any of those ligations, or arterial embolism. You don't see those very often, but I think some of the London hospitals do them still. And the last thing would be hysterectomy. If they cannot stop the bleeding, then they'll have no choice but to do a total hysterectomy, but it would be a last resort. Although some of the MBRRACE reports actually suggest that it should be done a lot more quickly than it is done. So thinking of some possible consequences, well, the most likely ones for us that you're going to see as a midwife is anemia. So what are we going to do about that? So post delivery, you're going to think about checking her HB levels. Does she need iron? Talk to her about diet. If she is anemic, then that potentially can have an impact on her lactation. So she may need some feeding support. These are quite traumatic events, so she may well be quite traumatized by this. So really think about, and it may or may not lead to postnatal depression, but think about referring her for some debriefing sessions if they happen within your trust. Certainly anyone who was involved with her at the delivery should come back and speak to her afterwards and just go through what has happened and why things happened. If she's very poorly, of course, there could be some separation from the baby, and that could affect bonding as well. And if we have, prolonged tissue hypoperfusion, then we could have some organ failure going on there. So again, we need to closely monitor that urine output particularly. Sepsis is an issue, particularly if you've had to do bimanual compression. We've done a lot of invasive procedures, so we need to be monitoring her quite closely. And kidney damage, we've already said, from that tissue hypoperfusion. And some of the rarer consequences would be things like anterior pituitary necrosis or Sheehan syndrome. And obviously the one we really don't want to happen is death. And there we have it, our whistle-stop tour through postpartum hemorrhage. I hope it's been useful for you. Please do feel free to subscribe to the channel and leave any comments below. And I look forward to seeing you next time.